Go ahead and get started. A couple of announcements before the program starts. There are still places available in the skills lab tomorrow afternoon if you're interested in the joint injection skills lab. And this evening is the reception and dinner at the Ogden Union Station. The Joe McQueen Band will be there, and the museums will be open till 8 p.m. And there are still places available at the dinner tonight. So if you wish, you can contact the administrative staff and they can get you tickets for this evening's event. I think that's really all the announcements I have. This morning's session will be chaired by Dr. Rhonda Lair.
Thank you, Harry. It really is my most enjoyable pleasure and honor to have been on the board of this wonderfully fun and informative organization for over 20 years now. Now, what's new my specialty is always a big it's one of the highlights of this meeting, and they tend to run over. So, Dr. Degener, our first speaker today, I'll have a little watch, and we'll try to keep on time as close as we can. But please ask questions. It's always the heart of any lecture. And I will just read the bios and make it short so they have more time to speak. Dr. David Degener graduated from the University of Colorado Medical School in 1974. After completing a surgical internship at Parkland Memorial Hospital in Dallas, Texas, he completed a 4-year residency program in anatomic and clinical pathology at the University of Colorado Pathology Residency Program in Denver. He completed the cytology subspecialty certification as well. His practice has included working from 1982 to 1992 in Grand Junction, Colorado, with Dr. Gino Sacamano, who established cytology lung mapping of lung cancer through decades of lung cancer surveillance in uranium miners in western Colorado. Dr. Degener has experience with ThinPrep and SurePrep liquid-based cervical technologies and HPV, chlamydia, and GC direct from vial testing. He currently works as the Director of Cytology at the Ogden Regional Medical Center in our homegrown other Utah hospital here in town. So, Dr. Degener.
Good morning, all of you early birds. If I can make sure this works. There we go. GYN cytology, Pap Smears, if you will, is the focus of my talk today. And I'm going to talk what's happened over the last 10 years as our world has been turned upside down, and then hopefully talk a little bit about what's going to occur in the future. The current science of GYN cytology is all based around the human papillomavirus and the study of it and the study of how it causes cancer, as well as other types of non-oncogenic diseases. And see if this works. Aha. You can see here that there are many, many types of HPV viruses that they can be divided generally into high-risk types and low-risk types. High-risk types are a group of these viruses that are felt to be able to progress onto cervical cancer. Now, as we have studied human papillomavirus and had the opportunity to therefore study this sexual-induced neoplasm, if you will, that, as you all know, whoops, can I go back? As you all know, that cervical cancer takes a number of years for it to appear, and we have many, many opportunities during that time to pick it up by Pap smears. Generally, the initial infection by the HPV virus is thought, all HPV virus infections are thought to be cleared quite spontaneously. The prevalence of HPV is very, very high, and that's why this line here is so very sharp. Usually this is about the age of when sexual maturity begins, and the prevalence of the virus. And if you look at our population today of adolescents and early 20s, the prevalence of the HPV virus is very, very high. Now, so what causes this virus to eventually, in a very small but selected population of people, to create cervical cancer? As you see here, there is the feeling that the body is able to fight this virus, that it's spontaneously cleared in the vast majority of cases, and it's only when the body cannot clear it that early premalignant lesions occur. And this is what we have been defined as dysplasia, or the premalignant findings upon the cervix. And then other types of cofactors are involved in order to get to invasive cancer. It's a little bit more complicated, and this is a greater explanation of the previous. As you can see here, here's the HPV virus infection. There is cancer. On the top are all the types of things that the host, the woman, has that either fights the tumor or allows the tumor to become established. And the bottom are some of the things that we think of as being co-conspirators, if you will, in this tumor process. So morphology is what Pap smears in the past have all been about. And in fact, it's been one of the most successful screening tools for cervical cancer, of any type of cancer. And we now feel that literally all cases of cervical squamous cell carcinoma are caused by this virus. In the world today, cervical cancer is a very high killer. It's the third most common killer today. But it's interesting, in the United States, the single greatest risk factor for cervical cancer is in patients that have never been screened. The last decade that I'm talking about has really turned our world upside down with automation and liquid-based technologies. And I'm going to talk about these testing methodologies, about the biochemical, the ways that we test HPV virus. And it's interesting, 20 years ago, the Pap smear was a lost leader. In other words, a laboratory, in order to get clinical lab business and anatomic path business, would throw in Pap smears on the side, and they would be very, very inexpensive. Those days are long gone. This is the beginning in our field of GYN cytology of what we call consensus conferences, and we'll talk a little bit more about that. And I'm going to talk a little bit about future testing, as there's many things around the corner. And I'm also going to talk about the Hpv vaccine. This is the first vaccine that specifically is aimed at a tumor process or a cancer. So, changes what we have. We're going to talk about morphology. We're going to talk about the histochemistry of HPV. We're going to talk about what's evidence-based recommendations. We're going to talk a little bit about vaccine. The things we're not going to be able to get around to are patient education, such as what your patients hear in the medical journals, such as Women's Day and things like that. There's politics here, and of course, there's big business and money, which we're not going to talk about. This slide helps us to get to the point of 50 years of progress using GYN cytology. Back in the 1980s, it was not a very closely regulated part of medicine, but starting with a CLIA 2, after everybody has heard of the Wall Street Journal expose, we've now become the most scrutinized, if you will, subspecialty of medicine. And it all begins in our technology quest with a thin prep liquid-based cytologies. I'm going to start with thin prep. This is the first liquid-based cytology process that was introduced and approved by the FDA. And you see here, this is the processor, the T2, and then subsequent to many years of work, automatic or computer-assisted screening had occurred, and that helps the cytotechnologist to focus their attention. Here we see several slides. The ones on the left side, your left-hand side, has a larger circle. This is a thin prep slide. The ones on the right-hand side have the smaller circle, and that corresponds to the second liquid-based technology, which is, it's interesting how these companies have evolved. There's been a lot of different terminology, all the way from SurePath, PrEP, Autocyte, the focal point, and now BD, Becton Dickinson, now is the owner of this, as little companies were gobbled up by big companies. And you see here, this is called the focal point. This is the machine that initially screened Pap smears, both conventional as well as liquid-based Paps, and subsequent to recent approval by the FDA, now is a computer-assisted location guidance system. And then this is the microscope that's driven by the information that the computer tells it, and the cytotechs use that in order to look at the cells. You have to remember, with this computer-assisted technology, there's still eyes that look at cases. And so what are the advantages and disadvantages? We're talking from conventional pathology to liquid-based pathology to computer-assisted pathology. Between thin prep and SurePath, it really depends upon what type of artifact that you want to look at as a cytotechnologist, cytopathologist. You have to realize that when you take cervical cells and you smear them out on a dry slide, namely a conventional Pap smear, you're doing things to the cells that are recognized. And the same, or I should say different types of things occur in liquid-based. For example, in thin prep, those same cells get pushed up against a filter. In SurePath, those same cells go through a gradient, but there is a unique set of morphology that occurs in each type of preparations. Now, you will see all sorts of data and literature that say this one's better than that one. The only thing I want to say about that is, for those of us that look at slides and look at cells a lot, we never want to go back to conventional Pap smears. Now, the disadvantages or the differences, there are differences in the techniques, and the differences between SurePath and thin prep is based upon several disadvantages. On thin prep, this technology has a very difficult time handling blood and mucus. In fact, it has a very high unsatisfactory rate. There are things that people that use this technology can do in order to help the situation out, but it is a very difficult situation. On the other hand, one of the difficult problems with SurePath is that the technology is such that the way it handles groups of glandular cells is a little bit difficult. But there are pluses and minuses. I have used both types of technology, and I'm currently using the SurePath. Okay, so the caveats in looking at morphology itself. It is a subjective science. In other words, we are looking at cells and how cells respond to disease. It's interesting that long incubation time, if you will, between dysplasia and subsequently the carcinoma, in some cases, is very short for reasons that we don't know. Another thing that morphology doesn't help us with, that cells can only respond or look a certain way. For example, Trichomonas produces cholelithic cells the same way that a mild squamous dysplasia. And for the eye, you can't tell the difference. That's why HPV testing comes into place. And also, there's what we call litigation cells. When the tumor arises up in the endocervical canal in the small metaplastic cells, it has a different appearance than if it rises at the transition zone or ectocervically. And these are the cells that are easier to miss. These are very difficult cases in which HPV technology has helped us. Now, I'm going to skip through this quickly because I'm behind time. Okay, we're now going to talk about a bit about the HPV biochemistry itself. Testing for human papillomavirus has gone through a transition up to this point here, it was all research-based in research laboratories. Starting with the hybrid capture 2 here, it's now a technology that can be done in many laboratories, and laboratories even are the size of ours do it. And what's interesting is the cutoff as far as the amount of HPV viral DNA is 1 picogram per ml. It's an incredibly sensitive test for seeing if there is any material from that virus. Other types of technology are PCR and immunofluorescent type in situ testing. Now, hybrid capture system has been around the longest. It's the one that is most studied and most used. And just a little bit here, the virus has to be opened up. There has to be an extraction phase. And then it attaches to a probe, RNA probe. And since the virus is present in such small quantities, it has to go through an amplification stage. And in hybrid capture 2 technology, the amplification is called a luminescence type of. Now, there are issues as far as the hybrid capture 2. This particular test was the first test on the market, and subsequently, it was a test that was in the right place at the right time. And so it played the key role in the ALT trial. I go back. Which is the ASCUS low-grade triage study on which all this information is now currently based. And let's go on. PCR is another technology, a polymerase chain reaction. It's a very, very sensitive. And when you look at the data, data is so subjective in a way, and you have to be careful that you're comparing apples to apples. In other words, your endpoint is, say, severe dysplasia or cancer or carcinoma or CIN2. You have to be careful. Now, I'm going to skip by that. There are both high-risk and low-risk HPV groups, which we saw earlier. And the high-risk groups, which include 16, 18, and all these other subtypes, that whole group of viruses are lumped together in the high-risk group and are identified through hybrid capture 2 as a group. And then the low risk are these down here, which include 6 and 11. As you can see up here, talking about cancer, adenocarcinoma, and high grade, the high risk HPV, those are the viruses that create cancer. In fact, as you can see here, the vast majority of cancers have high risk and not low risk. Okay, the caveats, again, all this technology, the caveats as far as the biochemistry is concerned, is that there are rare cases in which we haven't identified the HPV subtype that's causing this, this cervical squamous cell carcinoma. And I'm going to throw in also at least 70%, if not more, people that have adenocarcinoma in situ of the endocervix. It's also HPV-related disease. The costs. We've gone from Pap smears that were very, very inexpensive, and as all these tests have been added on, it's become more and more expensive, and the cost-effective ratio is being questioned. Now, should HPV testing be a primary screen with looking at the morphology secondary on abnormal cases, or should it be, as it's currently recommended, be an adjunctive type of test, if you will? In other words, Pap smear with HPV. Now, let's go on to other types of tests that we can see that come from the vial. Widely available that many, many laboratories produce from the vial include chlamydia, GC, and herpes. Tests that in the past, like the Affirm test for vaginal pathogens, Trichomonas candida, and Gardnerella, that is coming to be soon from the PAP itself. Physicians want as many tests out of this little vial as possible. And so the quest is on to be able to do more and more testing on that media. Now, PCR testing is controversial. This is a list of organisms that in some way, in some place, has been implicated that these may or may not be pathogens, part of the vaginal bacterial type of infections that can do things such as abortion and pelvic inflammatory disease and things like that. Now, with PCR, you can test for anything. If you can think of what it is, isolate the protein, you can do. But the caveats to this whole thing are it's very, very expensive. Insurance companies don't want to pay for it. In fact, these companies that coming out and offer laboratories offer this whole list of tests off of one simple vial. Initially, they say, okay, we can only do 5 of these tests in one vial because therefore we have a expensive test nearly in the thousands of dollars. As insurance companies become more and more educated, this is chomping down. This is chomping down. And you have to be aware that insurance companies really drive what tests will end up being able to be tested. Now, another thing is the balanced billing. These laboratories, as they come out, you have to be careful because balanced billing to the patient is that when an insurance does not cover it, they come back and ask for the residual part out of the patient's pocket. And we have to ask ourselves, what is the documented pathogen, a possible pathogen, and be able to sort that type of thing through what belongs in a research laboratory, what belongs in a common laboratory. Now, evidence-based recommendations, we're not going to go into that very much, but there's been a number of conferences, such as Bethesda Conference talking about morphology, 2 conferences by the American Society for Colposcopy and Cervical Pathology that have talked about criteria of how do you handle cervical pathology, both the cytology and the histology part of it. There have been, and then all the way down to the Bulletin 109 in December of the ACOG that has changed some of the has modified some of the ASCPP recommendations. Okay, we're not going to talk much about evidence-based science. Basically what it does, let's go back just a moment. All the articles and the types of investigative material is defined as either, I keep doing that, don't I? As defined as either what the strength of recommendations, the quality of the evidence, and subsequently what people would like to do is to have the most cost-effective way of doing this. We'll skip that for the moment. This is from the ASCCP, the guidelines, they're algorithms that can be found online, and I won't go into that. A little bit about vaccination in the last couple minutes. The first vaccine that has been marketed is Gardasil. It was approved in June of 2006 for girls and women ages 9 through 26. And more recently, in 2009, it's now approved for young men ages 11 through 26 for the Human Papillomavirus warts, if you will, for the low-risk condyloma. And it's by Merck and Company. It is a quadrivalent. It has with it, it tests for 6 and 11, which is a low-risk group, and 16 and 18, which is the greatest majority of high-risk groups. And we won't talk about that anymore. Its efficiency, in other words, the initial studies have shown it's very, very efficacious, and now it's found its way in MMWR and other places as being recommended in the vaccination cycle with other diseases. Now, the caveats with this is this vaccine has not been around very long. This is a disease process that takes up to 20 years to come to fruition. And so this vaccine has been around for about 4 or 5 years. How's it going to act over the long run? Are boosters going to become necessary? What about all those HPV types that aren't the 6 and 11? And the cost of this is very prohibitive to some people. And should HPV vaccination be mandated by law? This is a very controversial thing. The next vaccine on the market, there are only 2 nowadays, is Cervix and GlaxoSmithKline have a setup out here, but they're not, I didn't see anything there advertising their HPV vaccination. I don't want to read this necessarily, but there is a lot of controversy here. And one of the biggest controversies is what about people making mandated laws. And some states have introduced legislation to make it mandatory that all girls and women in this age be vaccinated. As you well can understand, that would be very difficult and is very controversial. I'm not going to be able to talk about these. Cytology is an upside-down field. In the future, there are going to be many new tumor markers that will be more specific to identifying when the virus has changed and the changes that will occur causing cancer. There'll be new recommendations. There will be new automated tests, more and more tests from the vial. There'll be new screening technologies. There will be controversy. There will be politics. And, of course, there will be considerations about money. Money makes the world turn around, it seems like. And so that's a thumbnail sketch of what is new in GYN cytology. I want to close by 3 interesting pictures of the Northern Lights. These were photographed in Alaska this last spring. This year has been particularly good with colorful Northern Lights. Questions? That mic's not on.
Okay, well, yeah. There's a mic on either side of the room, so if you're going to ask a question, either come up to this one or the one on the other side of the room to ask Dr. Degener questions. Did I understand you correctly to say that if you had no exposure to HPV, you wouldn't get cervical cancer?
That is the feeling, yes. That all cervical squamous cell carcinomas, the majority of adenocarcinomas of the endocervix, are specifically caused by the HPV virus.
If a woman or a man, for that matter, had been asymptomatic, had been exposure, had antibodies, are they at risk, but they never had any clinically manifest expression of the
When you look at the prevalence of the virus, in other words, in some populations in our teenage, early 20s women population, the incredible prevalence that they've had the virus at one time or another. And in most of these situations, the virus is cleared spontaneously by the body, and for the most part, we see a lot of times where we have negative Pap smear, but we have virus present. And you can have more than one virus type infection at once. You can have a low risk and a high risk together. But the body clears this out in the vast majority of cases.
And if it's cleared, we're assuming that you're not at risk for cervical cancer from that cause.
Exactly. The people that are at risk for advancement to cervical cancer are those people that cannot clear the virus adequately.
Thank you.
Other questions, or did I speak so fast that nobody wants to? You're supposed to go use a microphone. Run, run.
So currently the high-risk HPV results are lumped together.
Correct.
Right? So it would be helpful if they could identify which ones. Like, for example, if 16 and 18 came back positive, that might have an impact as to whether that person would benefit from the Gardasil shot or not. But right now they don't. It's just lumped as either positive or negative.
You are the person that I embedded in the audience to ask this question. There are the ASCCP as well as the FDA have approved testing for 16-18, which causes, it is felt, 70% of the high-risk cancer-induced tumors. And that technology has now been approved. It's called Cervista technology. You can also do it by PCR. But people that it's supposed to be used in 2 different situations. A DNA Pap, if a lady is over 30 and they have a DNA at Pap smear and a DNA test, the Pap smear is negative or reactive, the DNA is positive, what do you do there? The next step is to do a 16-18 to see if that positive HPV is 16 or 18. If it is, then that person should be triaged onto colposcopy. If it's not, then you have more time latitude. And then if you have difficult cases in which you have questions, why is the person repeatedly having high-risk HPV and should I be worried about it? This technology has been approved and for 16 and 18 using several different methodologies. Yes, question?
Yeah, I was just a little concerned about the one slide you had. It seemed to suggest that the timeline between HPV exposure and at least dysplasia was 10 to 15 years. And I just wanted to point out that I've probably taken care of 3 or 4 dozen young women between the ages of 15 and 19 that varied from as low as mild dysplasia to as high as carcinoma in situ. And I've seen carcinoma in situ in under 16-year-olds. So I just seems to fly in the face of what you were saying. But I understand that can be the case, but I just don't want people to be misinformed that, if you have a teenager, she's not at risk for having, carcinoma or, high-grade dysplasia or something along those lines.
You're exactly right. In fact, I've seen carcinoma in situ in a 12-year-old. And the initial recommendations of the ASCCP is that testing should begin within 3 years after initiation of sexual experience or by the age of 21. But we all have had cases of where the timeline, as in the one slide I had, the timeline is compressed. The timeline that's up here is the generalized timeline that it takes many years for this to develop, but not always. Any other questions?
Over here. Is the disease ever systemic? Or does the disease take place only at the site of the inoculation, purely genital through sexual intercourse? Or can any type of exposure to the contagion lead to a systemic type of disease?
When you look at all the different subtypes of the human papillomavirus, there are ones that are more specific to anal genital areas, just like herpes simplex 1 versus 2. But non-oncogenic types of HPV virus can affect other places of the body. In fact, oral carcinomas, squamous cell carcinoma of the esophagus, and other types of places rarely can have HPV found in them. How much of a causative agent it is, we don't know. But there are times on biopsies of a dysplastic esophageal lesion, we have condylomatous change, we test for the virus, and it can be there. But as far as the cause-effect causality, I can't answer. Yes.
Is there any evidence that the HPV virus could reactivate or that they could get the same virus again?
Okay. In the past, we always have the feeling with the virus that it can remain silent in the body over a long period of time. HPV virus has shown us that in the vast majority of the cases, the body clears it totally. And so if you have an HPV positive test now, and then 10 years from now, you go through another cycle of dysplasia and HPV and that type of thing, it is the assumption, in my estimation, that that's a different subtype of that same group of HPV viruses.
Would you care to comment on the use of rectal Pap smears in sexually active, rectally active gay men, and whether the same viruses are thought to be oncogenic?
Your question is good. The virus does cause disease, specifically genital warts, as far as the physical manifestation in the male population. As far as tumor genesis, based upon the type, that's not clear-cut. But yes, I have clients that they don't necessarily do a Pap study, but they will do an HPV test on this particular population of people. Yes?
Question. I'm a family practitioner. My question is there another vaccine that's bigger, better, more sexy on the horizon that within a year or two I'm going to be asked to be giving? Because, I mean, I have Gardasil available, but all of a sudden, is it going to be obsolete within a short amount of time?
I can't answer that. In our capitalistic society, I would say yes, but I don't know.
Okay. But you don't have any knowledge of what's the next one to come
I
out?
have not heard of anybody getting a vaccine to the point of usable. It's a very long and difficult and expensive proposition. That's why we only have 2 vaccines now. Obviously, people would like to hone in, have the whole high-risk group and stuff like that, but I don't know personally of anything like that.
Okay.
Thank you. Thank you.